Welcome to the Listen Up podcast, where we explore hearing loss, communication, connections, and health.
Hey everybody, Dr. Mark Sims here. I'm the host of the Listen Up podcast, where I feature top leaders in healthcare. This episode is brought to you by Listen Up Hearing Centers. I help patients to effectively treat their hearing loss so that they can remain better connected with family and friends and remain independent. The reason I'm so passionate about hearing loss is because I lost my brother Robbie twice. First to his hearing loss from his radiation to his tumor, and later when he passed away. I only care for ears. I'm the E of ENT. I've taken care of tens of thousands of patients with hearing loss and performed over 10,000 ear surgeries. I'm the founder of Listen Up Hearing Center. I'm also author of a book of the same name, Listen Up, A Physician's Guide to Effectively Treating Your Hearing Loss. If you want to learn more about that, go to listenuphearing.com. I have a great guest today. It's Dr. Amyn Amlani. He has been in academia and is currently the president of Otolithic, a firm that provides solution-based and outcome-generating consulting services specializing in accounting and business development in the hearing space. He's been in hearing care for a long time, 25 plus years, with extensive professional development. He's been in all forms. He's been in independent and medical audiology. He's been an academic and scholar and worked for industry. He's basically been around everywhere. And he's considered a leading national authority in hearing care with expertise in economic and marketing trends, consumer purchasing models, and provider service delivery models. He's a PhD in audiology and psychoacoustics with a minor in marketing and health economics and an outcome research certificate. Certainly, he's got a lot going on and a lot of credentials. Thanks for coming on, Amyn.
Hey, Mark, thank you for having me. Looking forward to it.
Sure. Tell me a little bit about your journey into the hearing space and how you ended up doing what you're doing.
Yeah, so it's a little bit interesting. I'm going to go back to high school days when my parents used to own a dry cleaners, and on lunch breaks and after the vans would go out with the clothes that went out to the satellite stores. I would go and watch these guys put car stereos in vehicles, and big competitions and things used to occur here. And so that was kind of my first taste into sound.
You mean the competition for loudness of the sound systems? Is that what you're talking about?
That's exactly it. It was a big thing back in the 1980s. And at one point, a gentleman got injured, and I actually got to participate. And I ended up working for these guys, a couple days a week. So that's where I get my passion for sound, and that's kind of where it started. But I really didn't get into the audiology realm until I was, probably a sophomore in college.
Sure.
I was an economics major, business major, and I just didn't know what my future held. I didn't have a lot of guidance. And I thought, man, I got to get out of this because I'm kind of a people person. I like talking to individuals. Sitting here with these numbers all day is not going to get me where I want to go.
The spreadsheets were not your passion.
That's exactly it. And so I ended up transferring from the Dallas area out to California, going into pharmacy, thinking that would be my path. And my advisor was a speech pathologist by the name of Simile Smith. I had to take a couple of core classes. First one happened to be into audiology, and I was hooked. Still really good friends with Simile Smith, who was at the University of the Pacific. She just retired. Bob Haniak, who just retired a couple of months ago, and then went on to Purdue and then on to Michigan State. So it's been an interesting journey. But I would not have been there had I not decided to change majors and then have the speech pathologist say, "Hey, why don't you give audiology a chance? You've got this sound background. This might be your calling."
That's a very common story, I will tell you. So you were in academia for quite some time. Correct?
Yes.
You were chairman of department, if I'm not correct, right? And so
that is true.
How'd you transition? I mean, obviously, it sounds like there's always been an inkling of the business side of things based on your original side. But tell us how you got into kind of an expertise on delivery service models, economics, marketing, outcomes, et cetera.
Yeah. So I'm going to go back a little bit. So as I was finishing up my dissertation, I actually wanted to go work in industry. So this is in the late 90s, early 2000s. And if you'll remember back then, there were, loads of different hearing aid manufacturers, Electone, Microtech, and so forth and so on.
Or the consolidation, right?
Yeah. Well, there was a lot of consolidation. acquisitions, mergers, and so forth and so on. And an individual on my dissertation committee had said to me, you got a young family. So I just got married. I had a young child. Says you probably don't want to go into industry right now. It's a little bit unstable. There's a possibility that you might get laid off. Go into the academic arena for a little while. Start there, and then as the dust settles, you can decide what you're going to do, which is what I did. So I took a job at Texas Tech University, trying to come back to the Dallas area, which is where my wife and I are from, and ended up staying there. Now, the academic arena is a fun environment in the sense that you get to take and mold students. And I really, really enjoyed that. But I was missing the other piece of this. And that piece was, why is it that people do not adopt amplification and hearing care services? And my appetite was actually whetted when I was a graduate student at Purdue. Sergey Kochkin had just been hired by Better Hearing Industries the Hearing Industries Association, and they had opened up the Better Hearing Institute. And I was sitting there with David Goldstein, who's the father of the AUD, and we were looking at some of the new things that were starting to come out, including the market track surveys. And there was a paper on the Marlboro Man. And the Marlboro Man paper was supposed to enlighten the audiology community by basically saying, if we get in the right people who are famous, then the public will follow. And as you know, that didn't work out so well. The only thing that really worked well was when Ronald Reagan decided to get hearing aids, and you saw we had a relatively large growth during that time. But anyway, it was wedded during there, and I was missing that piece, which you really can't operate, at least back in those days, a university clinic like a private practice. We were really constrained to what we could do. And so we got into the business of looking at pricing and economics and what were those barriers. We got into the psychology of behavioral psychology and looking at perceived value. And then it was when I decided to become a department chair that we went into a med school, and we were then allowed, because we had two clinics. We had one that was part of the med school, and then we had one that was kind of in a shopping center, and we could toy a little bit with how the model was going to work. We ran into some issues with personnel, but we were able to do a few things. And then I decided, well, I'm tired of this academic world, and we can talk about this in just a second. I had a real hard time with the student loans that students were getting, and the fact that once they graduated, they were struggling. And I thought, well, you know what? If I'm going to make an impact and I'm going to be happy, I got to get out of the academic environment, and maybe I can help folks on the other side of the coin where they're working in the business realm. And went to work for GN through Audiology. Had a little bit of a hand working at GN itself on some projects. And what I noticed was two things. Number one, we were still seeing patients like it was 1980. And this was, in the early 2000s, 2010s. And things just didn't sit well with me. The second thing that I noticed was we had not yet expanded our service delivery. We were just doing hearing aids when the AUD was supposed to give us more of a medical component, because you were going to get more expertise, more hours. When I was doing my master's, I think we had 350 or 400 hours. I maybe had 5 or 6 hours of vestibular because that's all that was required at that time. Today, it's a lot more different, right? You're expecting several, if not teens, hundreds of hours in vestibular and auditory brainstem response. And so the idea was people would start moving into that more medical realm. They don't, and we can get into this as well. It's because of reimbursement. They just don't get paid for those kinds of things.
Yeah. I mean, it's a tough model, certainly. And so, I mean, that does, it's interesting because, I think, it's multifactorial, right? The big question is why is there low adoption, right? And I think that's a huge question. And I'm not sure there's as much clarity as people think there is in that question.
Yeah, and what we've started to do is I was always under the impression that it was on the patient's side. What were the barriers that were keeping them there? Was it price? Okay, we resolved that. It's not necessarily price, it's value. What's in the value of the device? Well, it brings you audibility. But then there's also other pieces. And as you pointed out, it's multifactorial, right? So can they get a ride to the appointments? But then there's also the provider side. And on the provider side, are we taking too long by not, are there too many appointments, which takes them too long to get the help that they need or the perceived help that they need in order to move forward? And sometimes that lengthy journey within that trial period is because people aren't doing best practices. They're not doing real year, which we know is really low. We're not counseling folks like we did back, in the 80s and 90s when I was a graduate student. So what is the inverse square law? How is it that you can improve your communication strategies by looking at someone while they're talking? Well, today everybody's on their phones and doing things. Back then, people would sign. Well, today you can text to people. How many people are using those kind of modalities to help folks? So the provider, to some degree, is more of a prohibitive factor in the adoption rate than what we had perceived down the road.
I personally think it is the factor. I think the low adoption is, my kind of paradigm about it is poor peer experience. What I mean by that is when you talk to somebody about hearing aids, or to read what I would call treat your hearing loss, they report poor peer experiences, meaning they'll say, well, I've got one friend who got the hearing aids and returned them. I've got another friend who has them and doesn't wear them. And I have another friend who has them and doesn't hear any better. So they have no enthusiasm because they don't get enthusiasm from the people they already know have been trying to treat their hearing loss. And I think that speaks to best practices. People, 90% of hearing aids have, factory settings. I think that there's a lot of provider falling short of what patients really need to get them to the point where they have maximum rehabilitation. And I think that's where it comes, because people say, well, I don't want it because nobody else is excited about what they have.
Yeah, no, I absolutely 100% agree with you. And I think that's where we now have huge opportunities given this new OTC ruling that just came through, the fact that there's now self-fitting. For the first time in our history, we're actually fitting 4 different generations of consumers. You've got the silent generation all the way down to your millennials. You go from not being tech savvy to being extremely tech savvy. And I think you're going to see some really interesting developments over the next probably 10 years in the profession. I think some of it is going to be very, very positive, and I think also some of it is also going to be very, very damning.
Well, I'm not sure if damning or how about is going to weed out some of these practices. How's that for an answer? So,
I'll tone it down a little bit. So I'll go with you and say that, yeah, we'll probably weed out some folks.
Well, look, if you're going to charge several $1,000s to give people the equivalent experience of that they can get for an OTC for sub $1,000, you're going to have a hard time convincing people to pursue hearing care with you. That's the problem. Like, there is a good fraction of the population, of the hearing care population, that's providing not much substantially over a self-fitting hearing aid.
Yeah, no, 100%. And I'm going to go back to this comment of damning. And the reason that I use damning is think about the number of audiologists that are in the profession. So we've been working on this. So I've been working with Dr. Victor Bray at Salis on this for a couple of years now. In 1999, when the Bureau of Labor Statistics actually gave us our own number that separated us from speech, we had roughly, I'm doing this off the top of my head, we had roughly 13,000-ish audiologists at that point in time. The most recent number that we've looked at, I think, is in 2019, and it shows 14,000 audiologists. We should have about 20.
Population gone up since then. 35% of the United States. Right?
Yeah. So we should have about 20 to 22,000 audiologists or something. If you just add up the 600 or 700 graduates over that span, right? So the question becomes, where are they? So that's one question. And
there's a high attrition rate, that, right? So there is a high attrition rate.
Well, it's about 25 to 40%. And that's where it's damning, because if we lose more providers, who's going to service all of the people that need help? Because even the OTC folks, the literature shows, need some sort of professional help in some regard. They want answers. They want questions to their. They want answers to their questions.
Yeah. No, it's definitely there's a manpower, and then put on top of that the level of debt that many of these students are going into to get into the profession, and then the level of overall remuneration relative to that debt service, and it's a pretty unfavorable circumstance.
Oh yeah, I think we were estimating based on some of the work that we're doing that the debt is somewhere between $150,000 and $200,000 for an AUD. And again, BLS data shows that the average pay is between about 80 and 85,000. So, you've got twice the debt of what you're making. How do you get out of that debt? And then so people go into these jobs. They're working long hours. There's no satisfaction from a remuneration standpoint. And you're right, they're dropping out. And we're being a little bit sexist, but also, following the data here, we're primarily a female-dominated profession. And they start having families and they don't want to work full-time because they want to spend time with their children. And I certainly understand that, having my own kids and my wife wanting to do that. But then they don't come back into the marketplace after a period of time, and it's that's one of the reasons we are where we are.
So where do you see? I mean, all right, we're in trouble. Fix it. How do we fix this?
Well, it's a good question. So, I mean, we have to look at using ancillary audiology personnel. Now, whether those are assistants depends on your state licensure. I honestly think a number of years ago we had the opportunity to grandfather in or partner. I'll use that word instead. The hearing instrument specialists with audiologists. If we had done that, I think we would be in a very, very different situation, both politically, and also from a reimbursement standpoint, because we would have the sheer numbers. And by now we would have had the opportunity to elevate them, but also elevate ourselves into doing more things clinically. And I'm not saying that ship has sailed. I just think it's probably going to be a little bit more complicated today than it probably was about 20 years ago.
Do you see the programs going down to 3 years as a partial solution?
I think you'll see some programs go into a 3-year cycle. The problem that we have is we keep adding more programs. We don't have PhDs to teach. We don't have enough faculty to actually go in and teach the correct courses. So to give you an example, you might be having somebody teach a course in auditory processing disorders, but that individual only knows the basics. They can't get into the meat and potatoes of what that really constitutes. So where's the knowledge and the breadth and the depth that's needed to really understand what those faculties are, where those breakdowns are, and then come up with the treatment plans to help these individuals. And so we're band-aiding a lot of the subjects that are being taught. And I think we're actually putting out a poor product than we would have, a number of years ago. So to answer your question, we don't need more programs. We need fewer programs. And we probably need to take our existing curriculum, which was developed back in the 70s and 80s, and restructure it to where it probably has about 70 or 80 hours initially, and then has an advanced component to it. So maybe, the first piece of it is essentially the master's degree, where audiologists can get their licensures, they can earn a living while still going to school, help the public as they need it. And then maybe if they wanted to go back, they could do the more medical things like vestibular, auditory processing, electrophysiology, cochlear implants, and so forth and so on.
So maybe 3 tiers, right? Master's, AUD, PhD. Is that what you're referring to?
So I'm thinking, maybe master's and AUD for the clinical side, and then you could go master straight into the PhD if you wanted to do your research component. And that would alleviate a couple of years, because that's one of the reasons people don't get PhDs, because you have to get the AUD in a lot of cases, which is an additional 2 or 3 years worth of student loans in time out of the professional workforce.
And so where do you see audiology's will in terms of making the change that you're talking about?
I don't see it at this point, and I say that kind of cavalierish because I don't think those conversations have really surfaced. I think those are things that people say we need to talk about, and I know they're in the back of the minds of some folks, but we keep looking at our nose as opposed to looking 10 yards down the road to see what's coming at us. And so we need to really start looking ahead at the future, because if not, it's going to be short-sighted and we won't be here. Someone else is going to invade our space. So, think of OTCs as an example. These the devices are going to be available in pharmacies. At some point, those pharmacists are going to become specialized in these devices. Then what's going to happen to the audiologist? Because it's the same kind of counseling, and the audiologists aren't doing the real ear and the things that are necessary to fit these devices, and they're self-fit anyway. So why would I go see a professional? I already have a substitute to take that person's place.
I don't disagree with you. I mean, I would turn to your experience and wisdom. I mean, I'm a physician looking from the outside, but the things you're saying are not surprising to me, and I think are a challenge for the profession.
Yeah, and I think these are opportunities. I mean, audiology now has a fork in the road, and the opportunity here is, hey, let's look at ourselves very critically and let's make these changes. And by making those changes, the ideas will become more resilient. We're better educated, and we're now moving in the right direction. We're going to have some attrition, which, as you pointed out, is good in some ways. It's going to hurt us initially. But I think it's a huge opportunity to do the right thing, and then put ourselves back on the path to increased reimbursements and things. But that dip in the middle is going to hurt for a while, and it'll be interesting to see how my peers who are in the space and coming into the space handle that, because it's not going to be a smooth ride. It's going to be quite turbulent.
So do you see a lot of people sharing your macroscopic view of this? I mean, I don't disagree with you, but I mean, I wonder, are you an outlier in terms of these articulations, or are there other people articulating?
So, there's a small group that I have these conversations with who would, for the most part, would agree with what I'm saying. I think the vast majority would probably disagree and say that there's a better way. The people are always looking for, I don't want to use the word shortcut, but people are looking for more simplistic ways to make these changes.
No, it's a complex problem. I don't think it's going to be as simple as, let's do one and two things. I think it's going to be a multifactorial thing. I mean, I agree with you.
Yeah. And so I think from that standpoint, people, just either aren't aware of all of the nuances and the things that need to happen. And so I think from that perspective, I think it's a smaller number than what I would like.
And so, like, if you were to look in the future, let's say 10 years from now, what do you think it's all going to look like? I mean, I know this is like, it might be a combination of reality and wish, but what do you think it looks like?
So if I could get a crystal ball and kind of want things the way that I would like to see them, I would love to see a better partnership between the three components of the hearing arena. The physicians and the audiologists have to have a better relationship. And then the audiologists and the hearing instrument specialists, I think, could very well unify. There's a lot more crossover there in some of the things that we do. And then I also think we need to get the ancillary staff in place, whatever that's going to be, whether it's assistants or we're looking at other professionals to kind of add to their scope and work together within some bounds. So I think if we can do that, we can serve better people. So that's the first thing. I think the second thing is we need to better educate our folks, our students that are coming out, so that, again, we can put them in the right tiers. You got your undergraduate degree. Hopefully at some point in the future, there'll be an undergraduate pre-audiology program that's got a lot more science and
Right.
Those kinds of STEM programs or courses that to them. Get into the AUD program. Maybe it's a master's at the beginning. You can go fit hearing aids, get your license, go in and get your AUD. And then if you wanted to do a PhD in there, which we certainly need those individuals as well, we could then recruit those individuals. But by having that STEM background, more likely to get biology folks and engineering folks and so forth and so on. And then I think the third thing is we really have to look at the services that we're offering and do a better job of, really getting into the meat and potatoes of what those factors are and how we can better help the hearing impaired individual from a public health and from a medical standpoint. So to give you an example, let's look at cognition, right? So cognition has come into our world through these screeners most recently. Most academic programs, I would say over 90 to 95% of them, do not really talk about cognitive screeners and cognition as part of their academic curriculum because it's not part of the accreditation process. So now you have the MOCA and you've got these other technological instruments that are out in the space, and they're really promoting, hey, we need to look at cognition because we listen with our ears, but we understand with our brains. And we need to be able to separate those two. And we are now learning that hearing loss is associated with all of these medical pieces, right? These medical manifestations, diabetes, kidney disease, thyroid disease, and so forth and so on. And as those become untreated, you've got foggy brain, so to speak, just to keep things simple at this point in time.
Sure.
So now I'm putting a hearing aid on someone who has these untreated medical conditions, and I'm not getting the outcomes that I think I'm going to get. Well, they're not happy. They're going to return the device. They're coming in 10 and 12 times. They're dissatisfied. They're now bad-mouthing the product when potentially it's them and us because we really haven't taken care of the true root of the issue.
Sure.
So now if we're better trained and we can co-manage and say, you know what, your scores here on these screenings are a little bit low, go see a physician. Let's figure out what's going on with you. Well, yeah, okay, let's do some blood work. You've got low thyroids. Let's get you some medication. The fogginess goes away. The hearing aids work a little bit better. We use best practices. The world is a happy place. And so I think from those perspectives, we have huge opportunities. And that's where all of these pieces, I think, could really come together and really allow us to move forward and shine in the public health space.
Yeah, I agree with you. It's interesting. On the medical side, I think the cognitive care pathway is very immature as well. And so we, on the medical side, haven't really developed, there's kind of the screening and then kind of the next or the big step is neuropsychology and neurologists who deal in cognition. But that middle area, because if we sent everybody who got a positive screen to them, they'd be overwhelmed. They can't actually, there's not enough of them. So it'll be interesting to see over the next 10 years how that intermediary step gets fulfilled, right? Obviously, I think the neurologists who deal in this have a role, but they actually don't have a primary screening role, right? They're not going to be able to manage thyroid on every patient and hypertension and manage their diabetes and all of these comorbidities. There's got to be some, and so I think there'll be a big learning curve for the primary care space in all of this stuff. Not that they don't know about these diseases, but kind of looking at the connection between hearing loss, comorbidities, and cognitive outcomes. So it'll be an interesting, fascinating evolution in this particular space coming up.
No, absolutely. And I think, the technology that's also being developed. So if you look at e-health and telehealth and remote care and all these other facets that are available, even with the shortage of physicians, of family physicians in rural areas, hopefully with some licensure changes, you'll be able to see cross lines, maybe where things are a little bit slower, you can help folks across. So I'll give you West Texas as an example. If you're out in eastern New Mexico and the closest city to you is out in Lubbock, Texas, which is 150 miles away, maybe there's physicians there that could potentially treat somebody that's on the eastern side of New Mexico where we would have to drive that 2 or 3 hours just to get a little bit of help. So I think there's huge opportunities. Now, how all these pieces fit together, I think that's the big question to this puzzle. But the opportunities exist, and I'm excited about that.
No, I think it'd be interesting. It sounds like you're kind of right in the middle of all of these convergences. So it'll be interesting to follow up with you in a couple of years and say, okay, this is what you said it was going to be. Now, where are we? So I look forward to that.
100%. If we could buy a lotto ticket and predict those numbers, I'll play that game all day long.
Yeah, well, I mean, I do think though, I mean, if there's anything that really, the profound number you gave to me is 1,000 increase in audiologists net over the past 20 years, when certainly the elderly or needy, the population in need of audiologic services has gone up much more than, I mean, that's like 8% increase of manpower. I know the need has gone up way beyond that.
Oh yeah, 100%. The institutions, I think, are the to blame for that. One, because of the high costs it is to go to the institutions. Because in 2004, the federal government, who had preempted the costs of higher education expenses, turned it over to the states, and the states then turned it over to each individual institution. Academics are not good with budgets. I can tell you that, having lived in that world. They're just not good with managing those kinds of monies. And then what has happened is you've got tenured faculty members, you've got high expensive buildings, you've got all this large overhead. And when the states stopped appropriating monies, where else can you go? You got to go to the bottom, the consumer, and the consumer is the person that's having to pay for this. And it's not just in our field. I mean, it's everywhere, which is why Biden has this new, tax relief for the student loan folks. But it's a sad state, and the whole educational system on its head just needs to be corrected as well.
Yeah. Well, that's beyond the scope of what you and I are certainly going to tackle. But I mean, it shows you how policy forces affect and have real life implications, right? An untenable amount of debt for AUD students graduating relative to their income potential is a big problem. And, we're not going to get to, more growth with the population need if those problems aren't resolved. And I'll leave that obviously to your leadership and other people in this space to try to resolve these issues, certainly.
Yeah. And again, those conversations are taking place. Like I said, we've been doing a little bit of work. We've shared this with other leadership groups, and I know those conversations are taking place. And the hope is that there'll be a conversation, and then folks will start acting on it, because that's what we have to do.
Yeah. No, you got to get awareness to then be able to affect change. People have to know it. So everybody, this is Dr. Amyn Amlani. He is the president of Otolithic. If people wanted to get a hold of you, how would they get a hold of you if they wanted to talk more or learn more about this? Where would people go to get a hold of you?
Yeah, so you can certainly you can email me at otolithic@outlook.com. That's one way to get a hold of me. That would be the ideal way. You could also go to the website, otolithicconsulting.com, and then there's a contact page on there. And if you'll just fill that out, I'll get back to you.
He's on LinkedIn as well. I know that.
Yeah, happy to answer any questions and share whatever data that we have available, because knowledge is power. And the more people that are engaged in these discussions, the quicker we can resolve the issues that we're facing.
What project are you working on right now? Just out of curiosity.
Yeah, so that's so I've been working with a couple of manufacturers on pricing. With inflation going up and so forth and so on, we've been working on looking at pricing models for consumers, OTC devices, and so forth and so on. And I just recently won a contract with the World Health Organization, where we're going to be looking at some social barriers and how those social barriers are impacting people's abilities to gain access to healthcare.
Oh, wow. That's great. That's great stuff. So tell me, what's your favorite sound?
My favorite, this is a good question. So I like live music, but if I had to pick a sound that I am probably what I consider my most favorite, it's got to be a steak on a grill. I'm in Texas. We love beef. We like our big old ribeyes, and putting it on a grill. There's no better sound to me than that.
That's awesome. Everybody, this is Dr. Amyn Amlani. He is a president of Otolithic. It's a consulting firm around the hearing space. This has been a great conversation. I really appreciate your insights. Thank you so much for coming on the show.
Thank you, Mark, for having me. Appreciate it.
My pleasure.
Thanks for tuning in to the Listen Up podcast. We'll see you again next time, and be sure to click subscribe to get updates on future episodes.